Hey guys, I wanted to get out. Sorry, my screen's all messed up here. I wanted to go through some of the slides for this week because I know we wouldn't get through them in class. I'm starting with chapter 39, which is neurocognitive disorders. I will probably do another chapter as well, but this is where I'm starting. So, chapter 39 starts on page 757 in your book, and I'm probably going to refer a lot of tables as we go through here. So, bear with me as we go through. So when we're talking about neurocognitive disorders, your book talks a little bit about dementia and delirium. So cognition, what is cognition? It's just a system of interrelated abilities such as perception, reasoning, judgment. We've all had patients who maybe seem like they're with it but have terrible judgment. You might see that a lot in mental health. Same thing with the reasoning. They're not able to reason, but it seems like they're with it. Memory as well. And then dementia. They talk about cortical dementia and subcortical. According to your book, cortical is affecting the cortex. So if you can think of the cortex of the brain, and subcortical is deterioration of the deep gray or white matter. And even the brain stem, it said it could be in the subcortical. So delirium is typically acute, something that is acute, but it also needs to be treated as an emergency. It can be because of a lot of things, but it needs to be treated as an emergency. So what is it? It's impaired consciousness, less aware of the environment, and loss of ability to focus. There's a lot of reasons why someone might have delirium, which we need to be aware of. Some of the ones I wrote down are medications. Medications can cause delirium. We've talked about a lot of the side effects of the psych drugs and that they can cause lots of different things, really. The main one that they talk about in your book is postoperative, which makes sense, right? So sometimes people who go through ECT may have some delirium. They've been sedated, they've had conscious sedation. Actually, they've probably had more than just conscious sedation, and that can cause delirium. Risk factors, maybe a pre-existing cognitive impairment or a severe illness. Take some time and think about what other things might cause delirium in patients. And again, remember, it is an emergency, and we need to treat it. Some things I wrote down, or at least we need to bring it to somebody's attention, was infections, fluid and electrolyte imbalances, metabolic disturbances, hypoxia can cause that. Other predisposing factors that I wrote down was advanced age, brain damage or dementia, sensory overload, sleep deprivation, and there are probably more that you can think of. So teamwork and collaboration. Man, I just started and I'm already having trouble talking. Eliminate or correct the underlying cause. Okay, if they're hypoxic, they need oxygen, right? If they're a fluid and electrolyte imbalance, we need to get them some fluids. You know, just as well as someone who has like a UTI, maybe having some delirium, or someone who's dehydrated, maybe having some delirium. So we just need to understand the underlying cause. That's easier said than done, right? And work forward. Safety issues. We're going to stop anything that could be suspected as a medication that's causing this problem. And obviously, we're going to monitor changes in their vital signs, behavioral, and their mental status. Probably going to do a current and a past mental health status. Going to do a physical exam. I already said vital signs. Assess for any kind of infection. We mentioned UTI. So kind of go through all the things we know that can cause delirium, stopping all their medications, going through, any other things that we can think of, doing a neurological assessment to rule out TIA, and a pharmacological assessment. Your book also talks about a psychosocial assessment, their behavior, and their family environment. What's going on with them. So this could be someone who's in the hospital. This could be someone, who's coming in from home. But the end goal here is the end goal is to bring them out of the delirium. But what we need to do is literally a large assessment. We're talking family, medications, everything, to find out what is causing this delirium. Number one priority is safety. That's always our number one priority. The book even mentioned address any life-threatening issues. So respiratory issues, for example, if they're hypoxic, or cardiovascular issues has got to be our number one. So if you see something on a test about this Obviously, if someone is having those issues, that's going to be your number one. Think back to Maslow. Safety is really important. Combative behavior, the book talks about that a little bit. That can happen with delirium. De-escalation is a priority. That's the main go-to there. Psychosocial interventions that we're going to go through. Frequent interaction and support, encouragement to express their fears, frequent verbal reorientation, make sure their eyeglasses, hearing aids are all available. I think this is stuff that we probably already know and would do for an individual who is having delirium outside of mental health, even though delirium can happen anywhere. Again, correction of the underlying issue, resolve the confusion, and prevent injury. Again, there's your safety. There's your safety again. Okay, the book moves into Alzheimer's disease. That was delirium and dementia, or delirium really. And now it moves into Alzheimer's disease. Your book said 5.8 million Americans has Alzheimer's. 1 in 10 older than 65 years old. 1 in 10. Anybody over 65 years old, 1 in 10 has it. That's pretty common. There's a higher incidence in African Americans and in Latinos. The book didn't really say why. 5th leading cause of death among older adults. A lot of times there's a familiar link. I'm sorry, not familial, like family link. I think I said familiar almost the first time. Down syndrome has a higher risk, and metabolic syndrome has a higher risk. So those are some interesting facts I pulled from your book about Alzheimer's disease. Come on, there we go. So there's multiple cognitive deficits. Some of the ones you might see are aphasia. Know the difference between these. Alterations in language. We also see that in patients who've had a stroke, right? Aphasia. Apraxia, so impaired ability to execute a movement. Agnosia, failure to recognize or identify objects, or disturbance of executive functioning. I'm not a big fan of TV shows that are medically based. Like I'm sure a lot of you watch like Grey's Anatomy and things like that. But I did used to watch the show This Is Us. I got really tired of it and I quit watching it. But when one of the main characters in there was diagnosed with, I believe, Alzheimer's, she couldn't identify a clock, and that was one of the signs of Alzheimer's, is that you couldn't identify a clock. I don't know if you guys remember that, but so there's certain things that they can't identify for Alzheimer's. For Alzheimer's patients can't identify, I guess I should say. Family response to the disorder, obviously it's devastating, right? So this is more than just us just treating the patient. Now we're trying to help the family, help them get resources. There's a lot more resources today than there was 10 years ago for families who have a loved one with Alzheimer's. Long-term care responsibilities. A lot of times now units have an Alzheimer's unit, or nursing homes have an Alzheimer's unit. Some people can be managed at home. You worry about wandering, and sometimes these individuals can get aggressive, so safety might be an issue as well. This is a long clinical course, but it can advance quickly. The individuals I've known who've had Alzheimer's, it's went on for several years, but it does advance quickly and it gets worse. Treatment and collaboration to work towards recovery. Honestly, they're not going to fully recover, right? But we have to make this the best possible case scenario. Managing cognitive symptoms, trying to delay cognitive decline. Some medications can do that. And then treating the non-cognitive symptoms. Safety, I mentioned just a minute ago. So protecting the patient from injury and the physical needs of the patient. So during your mental health assessment, I'll just say, let me see how we're doing on time here. Okay, we got a little bit of time left. During your mental assessment, past and present health status, we want to know what other comorbidities they have. That's really important, especially when we first find out they have Alzheimer's. We want to get all this documented. You can do a physical exam and review of systems, self-care, sleep-wake disturbances, their activity, their exercise. When we talk about like their mental health assessment, like we also want to look at like their language. How are they speaking? Like you want to document all that. Documentation is really important. Mood changes, their anxiety. Are they having any psychotic symptoms like suspiciousness, delusions, illusions, hallucinations? And I'm sure all that is pretty common with Alzheimer's, especially if someone understands that they have Alzheimer's. That's very upsetting. And I'm sure that a lot of these things come to fruition and they do get suspicious about things. Oh, it's easier just to do that instead of click. Sorry, I'm recording from home. It's a little bit different. Clinical judgment, this is straight out of your book, word for word. I'm not going to read this to you, but it talks a little bit more about what happens as the disease progresses and what interventions that we're doing early on as the disease progresses and in the late stages of Alzheimer's disease. We want to promote self-care as much as we can. If patients can do self-care, and a lot of times these individuals have people come in and help them instead of going to a facility for as long as they can, because we want to keep them around familiarity, right? Physical health interventions, support of bowel and bladder function. Eventually they're going to lose it. Promotion of sleep, activity, and exercise as much as we can get them up, even just to walk, to keep getting their exercise, because if they sit and all day, they're going to have problems with other things. We're going to start to have cardiovascular problems, things like that. And promote nutrition, pain and comfort management. These are some of the medications they give for Alzheimer's. Acetylcholinesterase, I said it right? Acetylcholinesterase inhibitors. These are all in the boxes on 39.3 and 39.4. I believe that is on page. Page 775. They may be on other mental health medications like antidepressants and mood stabilizers to help them as well. Psychosocial intervention, so memory enhancement. Really, orientation is really important. We talked about reorienting a patient last week when we took the quiz. The other things your book mentioned that I don't have listed here is management of depression, management of stress, anxiety, things like that. Again, if you found out today that you had Alzheimer's, I'm sure some of those, you would have some of those same things: depression, anxiety over my family. They're going to have to take care of me. What are they going to do without me? Things like that. We're nearing the end here, guys. Other interventions that we may need to look for are problems with wandering. Typically, individuals with Alzheimer's disease, towards the end, they start to wander. Their behavior could be agitated. They could get restless. They could get combative. So there may be medication for that as well. Again, the priority is promoting safety. That is the big thing. These are other dementias your book talks about. They really don't give a lot of details about them. Parkinson's disease, Huntington's disease. I've actually known people with Huntington's disease. It's a horrible disease. And they have some other ones listed here. I don't plan to quiz you on those. The main issues here are going to be delirium and Alzheimer's.